Really, thank you, Dr. Pankaj, and I'm very delighted to be here in the World Congress of Cardiometabolic Medicine, and pleased to hear about TheRightDoctors.com. So, and I must thank to you for approaching a very interesting topic of the spontaneous coronary artery dissection. As you know, it often goes unnoticed, and whenever we see a typical MI or acute coronary syndrome, the first thing that clicked to our mind, whether I'm dealing with the atherogenic plaque, that's a rupture plaque, and things like that. Although I'm sure you must have realized in your day-to-day practice, it is kind of unusual presentation. And the first reflex is always when you see MI, you start talking about the revascularization by means of putting a stent. And here, since the etiology, pathogenesis is different, so do the treatment has to be different. And is unconventional than what we usually think of the way of revascularization by putting a stent. Over here, you have to talk about more of the pragmatic approach in terms of the conservative management, and then how you can essentially avoid the formation of hematoma. And when you say hematoma, you're talking about the intramural hematoma. And this is something, the crux of the management. Often at time we miss that or mismanage that, that leads to a more problem. Fortunately or unfortunately, I had a series of the patient not only have a one artery SCAD, he got all three vessels SCAD. And as you say that the profile of the patient is slightly different than we see in our conventional practice. Often a time they are young, physically fit people with some kind of underlying disorder. Commonly you see that the people with the fibromuscular dysplasia or connective tissue disorder or some kind of autoimmune disorder, when they have a risk of making a tear into the tunica media or tunica intima, and that eventually forms a flap leading to a complete occlusion of the flow across the dissecting point. And what happened essentially is that in between the media and adventitia, there's a big clot formation that leads to the hematoma. And that in a way is also protective and preventive, because once we stabilize that hematoma, that will also ensure a sealing effect so as to prevent further dissection. So it is important and kind of very imperative to identify this problem and treat it in an early stage.
Exactly. So you say this is more common in young females, physically fit people.
Absolutely.
And how do you decide whether to intervene these patients? Because some patients we do require interventions. So what are the precautions one has to take when we have to, suppose we have to do an intervention in this, it's not a flowing artery, you have to do interventions. Patient is very symptomatic and is not, we are not able to treat him conservatively. And if we want to do interventions, what tips you give to the young cardiologist when we are doing angioplasties in SCAD?
That's again a very interesting question, and you are absolutely right. The way to diagnose the SCAD, unfortunately, is interventional invasive coronary angiogram. Of course, you can diagnose with the cardiac CT itself, which they call as a first-line investigation. But the honest truth is that so somebody is presenting with you ACS kind of symptoms or ACS mimicking presentation. The first thing you wanted to do the invasive intervention cardiology, which means putting a wire down and putting a dye in. And now once you have identified or you have suspected that I'm dealing with the SCAD, our idea is not to make a further damage. So you have to ensure that you are intervening into the true lumen instead of the forced lumen. And whether or not, believe it, the 50% of the time when you do the PCI, they all are failed PCI. You end up having more problem. Often at time there are scenarios when you have absolutely no choice but to prevent the further dissection, you end up putting a bare metal stent or some kind of drug-eluting balloon, just balloon itself, not the stent. And that has to be actually guided, ultrasound guided, or you do the OCT. Now, conventionally, when you look at any kind of literature, they say it's relatively contraindicated, but you want to be very, very certain that what you did is in the best interest of the patient, and you want to ensure that the SCAD is not progressing further. So you need some kind of intravascular imaging by means of either iris or the OCT. And so happened in my case, I went on doing the OCT at that stage. I put it that way, ignorance probably was bliss at that stage, and I end up getting a very nice picture of those patient having a formation of the hematoma and the reducing the lumen size and all the way coming back to the normal lumen size, which was quite interesting. But at the same time, I did not intervene by means of putting any stent there. And thankfully, the patient responded quite well to the conservative management. One thing we probably have to take note of it while managing conservatively, you probably have to stay away from the antiplatelet or antithrombotic. You have to have a very pragmatic approach, otherwise you will worsen your hematoma formation at a later part of of your life. So I'm sure you certainly don't want that kind of worsening of a hematoma at any stage.
So what type of pharmacological treatment do you give to these patients?
Wow.
I mean, we don't give DAPT, we don't give long-term statins.
Absolutely.
How do you decide about the
So that's again very absolutely amazing question. And the conventional treatment is you have to start giving anti-anginals at the very initial stage. When you say the anti-anginal, you probably want to reduce the oxygen demand mismatch supply by means of reducing the heart rate by giving a beta blockers. Conventionally, I guess, my practice is often to give the bisoprolol, but I don't have any robust data to support one or other. But what essentially you want to do is reduce the heart rate by means of any kind of the beta blocker, what suits you. Also, what have actually proven of some scientific value is your isosorbide mononitrates. So as you dilate the vessels, which you basically what are trying to do is compressing the hematoma that has formed. When you refill the coronaries during the diastole, and by means of having nitrates, and then that will just reduce the size of the hematoma formation at what gives you an earlier, faster healing response.
That's wonderful.
Yeah.
So one final message for all the physicians about
so,
SCAD.
as I say, this is a very, not very, but commonly unusual presentation. And often must not miss it. So if you see a young gentleman with a different profile other than your conventional atherogenic events, you should always think in mind that whether I'm dealing with the spontaneous coronary artery dissection, and try to stay away from the stent, because we know the failure rate of putting the stent is quite high in those group of the patient.
Thank you so much, Dr. Ashok Tahilyani, for being with us and giving your valuable insights on this very important topic of SCAD. Thank you once again.
Thank you. It's a pleasure talking to you. Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.